All right, so my name is Sarah Finn. I am the local coordinator here for Community Works for Page. We are a local group of volunteers. We were initiated back in July of 2023, brought to Page County by the Rural Urban Bridge Initiative. We're part of their program and we're supported by the local Democrats. Our big goal is to do what we can do to increase collaborations across political differences. So we started off in 2023 with about 4 volunteers. We are now up to over 100 volunteers of all different political beliefs. So we have independents, Democrats, Republicans, people that don't care at all about politics, coming together under the main idea that we care about our community and we want our community to be a good place to live. So we support our local nonprofits, churches, any groups doing good work. We show up with volunteers and to support them. I want to thank you all for joining the discussion. I'm going to pass it off to our moderator, Skip Halpern, and he's going to kick things off for you guys. If you do have questions, please see me. I'm set up at the back table with a bunch of fun stuff that we've got going on over the next month. Thank you all.
Okay, well, thank you, Sarah, and thanks to all of you. I think it's great because this is a very timely and important topic, I think, for everybody, and hopefully you'll get some guidance here as to what's happening in the wonderful world of healthcare, but especially healthcare in this county. I want to begin very briefly by giving you summary descriptions of our 3 panelists, and our process here, we'll turn to each one of them individually with questions from their different perspectives, and I'll give you a fuller intro on each one of them as we turn to each individual. For now, Dan Sullivan at the far end, he's a navigator with an organization called Enroll Virginia, which helps individuals get and keep their insurance coverage. Next to him is Nikki Fadley, who's executive director at Strength and Peers that provides services to county residents with substance abuse disorder. And finally, Dr. Jeffrey Fite, who's this is a mouthful, so bear with me, Chief Population Health Officer and Chief Medical Information Officer at Valley Health. And Page Memorial is just one of the Valley Health locations. We also have in the audience here a number of different organizations involved with healthcare in this county. And after the session ends, I hope those people can make themselves known, and people here who want to visit with each one of them can learn more about them. That'll be shortly after 8 o'clock. In terms of the time schedule, we're going to split this roughly 50-50 in terms of presentations by the panelists, and then Q&A at the end, because I assume people will have a lot of questions. We'll do about 45, 50 minutes between some introductory things I want to mention, and then 15, 15, 15 for each of the 3 panelists, and then the remainder will be Q&A from all of you. Before diving in, I had 3 points I wanted to mention to hopefully help set the stage, help you follow the bouncing ball here. First of all, pay attention to the difference between funding healthcare and providing healthcare. The funding is typically through some form of insurance. That's the source for paying the provider, the source for paying Valley Health or Strength and Peers. And that depends on how many people are covered, with what insurance, and how many people are not covered. If the coverage is cut, guess what? The number of insured people drops and the payments to the providers drops as well. So one concern, and this is really critical, is that the impact of cuts on any one person seeking coverage is one thing, but then the other concern is the impact on the ability of the providers to provide health care to everybody, regardless of what insurance you have or don't have, whether you're Medicaid, under the ACA, whether you have Medicare, whether you have private insurance. Everybody in that sense is kind of in the same boat here. Secondly, some of the basic terms. We've got Medicaid and the Affordable Care Act, and then Medicare. And we'll be concentrating primarily on Medicaid and the ACA, because those are the ones that the recent legislation affects most directly. Medicaid provides funding for health care for people who essentially can't demonstrate, who demonstrate they can't afford to pay premiums. It's largely children, disabled people, elderly, indigents. Medicaid then provides some level of payments to the providers. The Affordable Care Act, affectionately known in some quarters as Obamacare or the ACA, that provides health insurance to people through a marketplace or exchange that Dan Sullivan will talk about for individuals, typically middle income people who can afford some premiums but need a little help from subsidies to pay the full freight. Medicare is also federal health insurance, but the cutbacks, as I said, don't directly affect that, so we won't be concentrating on Medicare this evening. Finally, we got 3 panelists and we've got 3 perspectives. We'll begin with Dan Sullivan from Enroll, Virginia, who's a navigator, talking about people seeking to get and keep coverage even under the new rules. And then we'll turn to Jeff Veit from Valley Health and to Nikki Faley from Strength and Peers to talk about the impact on their organizations as providers of insurance, providers of healthcare. Okay, turning first to Dan Sullivan. And I want to mention, Dan, your illustrious background so people know. Dan is a healthcare navigator with Enroll, Virginia. It's a project of the Virginia Poverty Law Center, and he has worked there since 2013. That's when Virginia consumers enrolled through the federally facilitated ACA marketplace, and then later, Virginia expanded Medicaid here, and set up the Virginia marketplace as well. Enroll Virginia provides free, unbiased assistance to consumers seeking access to health care. Dan graduated from the University of Richmond with an economics degree, then joined the Marine Corps, then worked for 7 years in what he calls the income tax sector, before moving on to Enroll Virginia. He serves on various local boards and commissions in the Valley. That includes 8 years in the Community Services Board, including 4 as chair, and worked 7 years as a volunteer with remote area medical, which Community Works also dealt with, and some of you probably participated because Ram was here recently. We're going to talk about the new requirements for coverage under Medicaid and ACA. Dan,
Well,
now,
yes, thanks.
can you give a little background on Enroll Virginia for openers?
So, Virginia Poverty Law Center had a senior attorney who, at the beginning, after the law was passed for the ACA, decided that she would get them to apply for the funding that is possible to provide navigators. It's part of the ACA, so that people can go for unbiased help, not be sold something by an agent broker whose motivation is which commission am I going to maximize. And Jill wrote it up, won it, and stole a senior attorney from Enroll America, which no longer exists. And we have lasted through all the twists and turns, including the defunding of the program, which has happened again, fortunately, because we lobbied to get the Virginia insurance marketplace the funding that the administration cut in the first time they went in, and now doesn't affect us because we have our own marketplace, so we continue to exist. That was a very smart move on Jill's part. She happened to be literally a next door neighbor of Tim Kaine when he was mayor. Now he's somebody else, and she has all our thanks for that effort that she did. She's retired now. I literally was looking for a job for my son when I stumbled across this. It looked interesting. I retired from the military. My perspective on medicine is completely different than most people's because I didn't have to struggle to find coverage. And fortunately, I've been healthy. What I have found out, though, is that, and remember I'm an economist, The pool that we all live in for medical care is the entire United States, whether or not you belong to an insurance company, Medicaid, or whoever else. Because in the end, all the medical costs have to be paid. And that really was put forth by the Reagan administration when they said that nobody could be turned away from an emergency room. So some of that is being complained about now can be pointed back to years ago. Medicaid initially really focused on children and pregnant women, and fortunately, the good news, and the only good news I can give you today, is that for the most part, they are unaffected. Even children who are not here with papers. So keep that in mind. Emergency Medicaid still exists. Of course, there's fear from adults who go to the emergency room that are undocumented, that if they apply for emergency Medicaid, that somehow that might put them on a list somewhere. That's bad for the hospitals. So how we handle things going forward is going to be interesting. What a lot of people don't understand is that the vast majority of people on Medicaid are women who are pregnant and children, and that among the adults that are not pregnant, most of them work. Probably 80%. The statistics aren't real solid. And the ones who don't work, some of them can't work. So regardless of what has gone to fore as far as stopping the people who shouldn't be on Medicaid from being on Medicaid, this is probably not going to reduce the number of people who are eligible for Medicaid. But I'll talk about some of the barriers to them getting on Medicaid now that this law has changed. What the law did do was change eligibility for immigrants. And that doesn't affect Page County that much, but there are immigrants in Page County. And before, there was a seamless coverage set that allowed immigrants who were not eligible for Medicaid, which are many, because you have to be a green card holder and be in the United States for 5 years to be eligible for Medicaid, could enroll in the federal marketplace or the state marketplaces. Now, that has changed. I'll address that a little bit later. It basically excludes everyone except those 5-year LPRs, the special immigration visa individuals. Those are significantly the Afghans that we kind of left holding the bag and brought to the United States. The Ukrainians are also among that set. And then anyone who has been involved in trafficking or Cuban and Haitian immigrants, which seem to always remain a significant case. And then there's the Compact of Free Association, which are those islands out in the Pacific that are associated with us, and we accept them as part of us. Now, except for them, the others are going to have to find some other way to get coverage. And in order for an immigrant who doesn't meet the Medicaid standard to get coverage in the marketplace, they're going to have to meet an income requirement. And that income requirement is 100% of the federal poverty level. That is a lot of money if you have 5 children. I actually did a case last week where a group who had fled the Congo, gone to Uganda, and come to the United States, the guy's working. He's working full time. He's not going to meet the requirement to make about $85,000 to get everyone covered. Now, fortunately, the children are covered, right? But the adults who are working, who won't have coverage and need to stay healthy to continue working, won't be able to go for care and have that care paid for. We're fortunate in a couple of places with the free clinics, but because of the number of individuals who are going to have to demand the resources of the free clinics, those free clinics are going to have to start triaging eligibility. And only individuals, so Harrisonburg's free clinic is now sending anyone who is eligible for some kind of coverage to me so we can meet that out and try to get them covered. But it's become more difficult. And let me tell you, trying to explain to somebody who has immigrated from another country where they had health care how our system works I can't do that to American citizens. It is hours that it takes to explain that. So it's a significant problem. The thing that's going to change on the work requirements for those adults is going to be the barrier. I work with a lot of local departments of social service. And none of them are in great shape. Nobody wants to work there. They don't pay enough. So the governor, if you recall, after COVID, told every state worker that they had to go back to the office to work. What he didn't know is that all those organizations like DSS and others are local. He can't order those people back to work, and they're not back at the office and available. That's difficult, but what that's done is for the Northern Virginia local DSSs who pay more, they can hire people away, the good workers away from the rural counties and let them work remotely. That is a real difficult case for the local DSSs. The additional paperwork requirements for tracking the employment are going to be horrendous. Fortunately, that doesn't start until the end of 2026, right? Now, what has started, though, is that elimination of eligibility for the immigrants, that large number of immigrants, and you mentioned Medicare. Even immigrants who have worked the 40 quarters, who have been here for years in a TPS status, temporary protected status, or another who would otherwise rate Medicare and no longer have Medicare. Okay? And those rules for immigrants began the first day of this month.
Dan, let me interject. For people who are longtime Americans living in Page County since forever, or citizens from birth here in the United States, what is the impact of the changed Medicaid requirements as you see it from your perspective?
So what's going to happen is that they are going to have to report now every 6 months, renew their eligibility. And when they do that, at a more frequent basis, I think it's every 3 months, they're going to have to show that they have met certain earnings or work requirements. Those work requirements can be hourly wages, working wherever. They can be volunteer work. Well, that's going to put a burden on the nonprofits. They're going to have to provide the documentation to demonstrate that they've been there. They can be in school. There are a number of exceptions that I actually have listed under a number of part of this set of papers here. I have about 18 or 19 sets of these over here, so I'd like it if you'd only take one per family, but they are over on the table, and they'll give like the details of what you're going to have to submit. That DSS right now is already overwhelmed with the workload that they have. Adding this onto their plate is going to slow things down significantly.
So let me, again, just to focus this, you mentioned that people covered by Medicaid tend to be children, indigent, elderly, disabled people, and then there's the category of eligible working adults eligible for working. Of the percentages of the people you're talking about now and the work requirements, that applies only to that category of adults of working age, correct?
Correct.
Okay.
Correct.
And what's the impact on disabled, and you've talked about kids, or elderly indigent, for example, people in retirement homes or nursing homes?
Well, and I was going to go there. The funding for providing care in the nursing and assisted living facilities is diminishing, and the move is to move individuals toward home care, but the hours for attendance have also been cut, and now today we're getting reports that that's happening to them right now. So that is going to significantly affect the individuals who are caring for them and their ability to go to work. So there's a cascading effect on that. And there's only, remember, there's only between 15 and 20% of the adult Medicaid recipients that aren't working anyway. Now, the requirement, what's really difficult is for like self-employed individuals who have to track their own hours and prove that they've had the income and the expenses, which, having been in the tax industry, I can tell you everybody's really sloppy on that. And the DSS is going to try to educate them, but they just don't have the time to do it. And I don't know how they'll be able to keep up with it. And then having to report and renew every 6 months, the tendency is going to be that they'll be off the rolls. Now, living, their families are going to have to take over their care.
Now, why would they, I've got the benefit of not knowing a lot about this, so I get to ask the dumb questions. Why would the elderly indigent no longer qualify for coverage under Medicaid?
It's not that they don't qualify for coverage under Medicaid, it's that the benefits are going to be restricted. The funding is going to be restricted, so you would be, there's a limit to how much is funded for that, so not everybody can get that. And remember, there are limited numbers of beds in the facilities, but that's also going to affect the facilities. They are going to have to end up closing because they're not going to have the payers anymore. So, and there's a whole lot in Virginia of very small assisted living facilities. That's a Medicaid care.
Does the ACA, with the possibility, maybe likelihood, that the subsidies will disappear, what's the impact on people currently covered through the exchange under the ACA?
So what I am seeing is an increase in premiums of about 500%. 500%. And so under the IRA, the Inflation Reduction Act, the subsidies were significantly increased. So you could get really good plans for low net premiums if you're low income, $40, whatever else. Even low income people have a hard time with $40. You multiply that by 5, and their propensity right now is to not re-enroll. What I'm trying to explain to them is that they should enroll, and if not in one of these really good plans that you're eligible for because you can't afford the $200, enroll in one that you don't have a premium in, that covers, your primary care, your preventive care, and your drugs. So at least the hospital can get paid, and you can get some financial assistance to get that bill out of the way. Because remember that about 50% of all bankruptcies in the United States involve medical debt. And, I was encouraged to take a look at what bankruptcies have happened, what has happened with bankruptcies since the Affordable Care Act, and I did. I looked up the Western District Bankruptcy Court of Virginia. And before the ACA, they were handling about 10,000 filings per year. At the ACA, it started to diminish in a nice little slope, but once Medicaid expansion occurred, it dropped dramatically. We are now at 50% of the number of bankruptcies filed every year that there were prior to the ACA. That's 10,000 versus, it's actually below $5,000 bankruptcies per year now. And that is really important for all of us. Now, so there's all kinds of theories, social theories, and remember that economists are sociologists who like math. So we like to study behavior, and what I can tell you and this is somewhat anecdotal, but I deal with these guys all the time, and I know some of these people I help, I've been helping for 10 years. I've watched them go through heck, and they struggle to get access to care. So even though Medicaid, for instance, expanded and allowed adults to have dental care, finding a chair at a dentist's office where they're going to take the Medicaid pay is very difficult. So just because you have coverage doesn't solve the problem. Fortunately, for other medicine, you're better off, but for behavioral health, you're not.
We'll get to that with with Nikki for sure, but let me ask you one last question before passing the torch to Jeff here. What's the impact that either you've seen or you expect to see in terms of opioid treatment, for example, of cutbacks in Medicaid, the threatened cutbacks in the ACA?
So that's a real problem because those individuals who have those problems now, they meet one of the criteria for not having to meet the court requirement if they're in treatment. Okay, so the treatment can get paid for, but Nikki can address this better than I can. People wander in and out of treatment, and that will keep them from being able to get treatment going forward. The other thing is that even if they're able to work and get into the marketplace plans, most marketplace plans are going to be co-insurance for behavioral health care. And no one can afford those.
Okay, thank you. Thank you, Dan. Let me turn next to Jeff Fite. Jeff collaborates with various community partners to advance health and wellness efforts throughout this area. Joined the administrative team at Valley Health in 2012. Was Vice President of Medical Affairs at Page Memorial Hospital. Prior to that, practicing medicine here in Page County, and also practiced family medicine in Fairfax, Virginia as well. Jeff earned his medical degree and completed a residency in family medicine at the UVA School of Medicine, has a bachelor's degree in international affairs and public policy from Princeton, and a master's of science in healthcare administration from VCU. Jeff is going to talk about the impact of these recent changes on the health of Valley Health financially. And I wonder if you can start, Jeff, with a quick overview of Valley Health and especially Page Memorial.
Sure. Thank you all so much for having me. It's so nice to see so many friends. And thank you for putting this together and hosting this. So, as I think you all know, Page Memorial Hospital, which has been here now for 80 some odd years, has been part of Valley Health since 2009, I think. Valley Health has 6 hospitals throughout the valley in Luray, in Warren County, Shenandoah County, in Winchester, and then 2 small hospitals in West Virginia. We have 40 or so medical clinics at this point, a handful of urgent care centers, and are the primary provider of healthcare services in the northern Shenandoah Valley. And we're really privileged to do all that work. We've grown, we were looking at this not too long ago, we've grown by about 50% in the last 6 years. It's just been a tremendous growth period since COVID. Coming out of the pandemic, things were going pretty well. And one of the things about healthcare, we're a not-for-profit healthcare system, which means we don't have shareholders. Any money that's left over at the end goes right back into the business, right back into how we serve the community by improving health, which is our mission. And we were on track. Coming out of the pandemic, a lot of health systems have struggled financially. Only about half of, probably fewer than half systems in America are in the black. And we were on a nice glide path trying to get back to a magic number that we look at, which is 4%. So we're $1.5 billion health system. And we are trying to get to a profit per year, profit in quotes, because again, it goes right back into building new healthcare buildings. We need to have $60 million a year above the line at the end to build the new buildings. We build new hospitals in all of our communities, new medical practices. That's the amount of money we need to satisfy our capital needs to continue to serve our communities. And we were on a track after the pandemic to get to that 4%. So $30, $40 million a year of profit over the last couple of years. The impact of HR 1, the bill that was passed that changes Medicaid, is about $60 or $70 million a year to Valley Health. So that makes that path a little steeper. We live in our communities, we love our communities, and we are here to fix that problem and address that need, but that's the size of the hole. I'm happy to talk about sort of the details of that and how it happens, but that's really the hole.
Yeah, when Jeff and I were talking before the session started, and that was really the bottom line. So you do the math, 4% on $1.5 billion, and that's what you need to continue functioning, and the hole you're facing now is that plus a little bit more. Yeah, so you're gonna have to rearrange some chairs on the Titanic.
There's a tip jar in the back.
Yeah, good. Yeah, good. Contributions are welcome. Okay, can you talk a little bit about the service model? That is, when you're serving patients who are covered by Medicaid, are you making money? Are you losing money? Are you breaking even when you talk about Valley Health as a system?
It's complicated. In general, Medicare and Medicaid pay less for healthcare services than it costs us to deliver those services. There are some nuances to that with things called critical access hospitals, of which PAGE is one, and rural health clinics, of which family and internal medicine here is another one. So there are structures that sort of trim that gap, but it is fair to say that in the big picture, we get paid less by Medicare than it costs to deliver services. We get paid less by Medicaid than we get paid by Medicare. Getting some feedback here. It's probably worth talking about the three different ways that we get to that 70 million number, because two of them we've kind of covered here and one we haven't really. So the two we've covered is that through the increased work requirements, we think people will lose Medicaid eligibility, fewer people with insurance. We've gotten down to a much smaller number of uninsured patients that come to us needing services. And we see, I should say this out loud, we see people who come to our emergency room regardless of their ability to pay. We see people who come to our clinics regardless of their ability to pay. And we have a generous financial assistance plan. Anybody who's below 200% of the federal poverty guideline can give us documentation for that, and we provide them services free of charge. Between 200 and 300% of the federal poverty guideline, we have a graduated program. So we have a generous financial assistance program that has some of the same challenges that Dan was talking about, which is we have to get documentation and paperwork changes, and people have to reattest over time. So those are burdensome processes, but we're happy to do that for our community. The problem is that doesn't get people medicines, and that's the big expense we can't cover. So you can come to a Valley Health rheumatologist because you have rheumatoid arthritis and you're suffering every day, and you can meet our criteria to get seen free of care, but you can't get your medicine because we don't provide that for folks. So even with that financial assistance program, it still creates barriers for folks. Anyway, one of the categories that creates that 70 million is people who will lose coverage. They'll go back to being uninsured. We will still see them, we'll still take care of them, we just won't get the revenue. The second we've talked about are those credits. So people who currently have coverage through the marketplace, they meet an income threshold, they buy their insurance, but they get a subsidy, they get a credit, and they can afford to pay for that. If they lose that insurance, again, we still have the patients, but we don't have the coverage. So in that situation, they're buying into a commercial product. They come in with a card that says Aetna or Cigna or Anthem, but they bought that through the marketplace. We would no longer get paid. Those would become uninsured patients. The third one's actually the biggest one. And this is
Just to be clear on that last point you made, they no longer have coverage because they can't afford the unsubsidized coverage.
That's right.
Okay, thanks.
The third one is the hardest one to explain, and it's the biggest bucket. So I guess I'll tell it as a story, right? So after the Affordable Care Act was passed, 2016, right? States started to consider this question of should we expand Medicaid. What's different, a couple of things Skip talked about that are different between Medicaid and Medicare is that Medicare is a federal program. Medicaid is a joint program between the states and the federal government. The funding comes from both. And so part of I'll use the word trick, it's not exactly a trick, it's just one of the facts of expanding Medicaid is that if states expanded Medicaid, they could bring in more federal dollars into their state, right? Because for every dollar the state puts up to expand Medicaid, they get money back from the feds. Adding on to that, the original Medicaid federal-state split was 50-50. The expansion that came with the ACA was 90-10. So for every $1 you put in on the state side, you get $9 on the federal side, incentivizing states to expand Medicaid. Because it was the stated purpose of the ACA to expand coverage, right? They would leave no one behind. So states expanded, and they got $9 back for every one. Well, many states, including Virginia, the state government said, we can't even afford that one. And the hospital said, we got you. We'll pay the one. And they created a tax on the hospitals to pay for our portion of the state portion of Medicaid. Okay. So what happens when you unwind that? which is what's happening here, is we lose that expansion. Right? We lose the ability to bring federal dollars in, and it reduces the amount of money we can draw from the federal government to cover the Medicaid patients. So even folks who have coverage, that rate comes down. So two of the things that change our payment are based on the number of people covered. One of them is based on the rate that Medicaid will pay based on those changes. And the formulas are complicated, it's really not worth getting into, but the bottom line is that the amount of money we would get paid to take care of Medicaid patients would dramatically go down. Still the same patients. We live in our communities, we take care of our community, but the paying mechanisms all change. So those are the challenges we face.
Sounds like a piece of cake. So the different buttons you can push to try to deal with the shortfall, just in general terms, would include staff, would include medical equipment, would include attracting and retaining medical professionals, would include buildings and facilities. What's the plan? You just juggle among those to try to close the gap?
I don't know that there's going to be a plan, one plan, one thing you can put your finger on. We as a health system, I'm blessed to work with resourceful, smart, effective people who will look at this like we look at any challenge and say, how do we serve our community given our new environment? And that's the work we have in front of us and the work we sit and we do every day, as leaders of this. And Mark Nance, our CEO, frequently refers to Valley Health. This is a mission. We are here to do work on behalf of the community. And so, on behalf of the communities we serve, how do we meet the moment? I think will there be rationalization someday of some services in some communities? Probably. Will that be the only mechanism? No, certainly not. We'll have to be creative, and we'll have to solve problems, and we'll have to do a little more with a little less. That's never fun. But that's our goal. Our goal is to be here, be an independent, strong healthcare system like we've been for many, many years, and continue to do that.
One other question, just as a layperson. I understand that there's a differential between preventative and primary care versus emergency room care. How will that differential play out to the extent people lose insurance coverage? In other words, to what extent will we likely expect more people coming into the emergency room, and what will be the cost impact of that?
It's a good question, and again, the answer is it's complicated, right? And so, as a family doctor, I certainly believe that the best care is provided by a continuity-based doctor who you get to have a relationship with, and who knows you and knows your family, and can help you, work through the challenges. And when you don't have insurance and you're afraid of going to the doctor, you wait till you're sicker. And on one hand, that just costs more because emergency rooms are super expensive places with lots of machines, and you end up getting a lot more tests when you're in an emergency room because the doctor doesn't know you and they're worried you're dying. And there's all sorts of things that have to get done in the emergency room, so it costs more to take care of the same problem. It also leads to fragmentation of care and all the evils that come with that. So it's bad for how we can deliver care. It's more expensive. It's less efficient. All those things.
One last question before passing the mic over to Nikki. My understanding is that late in the legislative process, there was a proposal which was adopted to create something on the order of a $50 billion, I'll call it a buffer fund, maybe a Band-Aid, to deal with all this. Can you explain to what extent that's helpful and to what extent it still leaves a big shortfall?
I'll do the second part first. So it's a $50 billion fund after $1 trillion reduction. Yeah. So you guys can do that math. That's it. $50 billion is a lot of money. Half of that is being distributed to the states evenly. So that's without regard for population. So Hawaii gets the same amount as California. The other half is a competitive process where we will be applying as a state. So the Commonwealth will submit an application that may or may not get additional funding from the other $25 billion, and that will be judged by the current administration as to which state is most deserving of that funding. We've been working with the Virginia Hospital Association to craft a... do that. It's just how it works. We're working with the Virginia Health and Hospital Association, and we've put in a series of ideas on how we think we can transform rural health. everything from getting funding for workforce development so we can develop more nurses in rural America, to working with an AI company to develop programming so we can help folks with their advanced directives. A lot of just different ideas, ways we think we can impact rural healthcare, and applying for that money, and we'll see how that goes. That's in process.
Okay. Thank you. Nikki Fadley, who's the founder and executive director of Strength in Peers. Nikki reports that her work is really grounded in her own lived experience dealing with mental health recovery and overcoming trauma, and she focuses on developing peer recovery support programs and advocating for those who struggle with behavioral health challenges. She's got over 12 years of experience in the field of nonprofit public health, including 7 years in grant writing and program management. She earned a master's degree in public policy from George Mason and a bachelor's degree in political science from JMU. As you put it, Nikki, recovery means I understand who I am, how I feel, and what I need. It's knowing that I'll always walk through thunderstorms, but they will pass, and believing that I'm worth the same love and grace that I shower on others. And Nikki will be talking about the work that her organization does in Page County, including relationship with the Sheriff's Office here and the JMAT program. Could you start, Nikki, with a summary of your organization, what you do specifically in Page County?
Thank you all so much for having me. So Strength in Peers, as Skip said, is a peer-run recovery community organization. So yes, I am a proud person in recovery. All of my staff identify as being in recovery from substance use, mental health, and trauma-related challenges. And what we do every day is peer support, helping people recover, overcome their challenges by being authentic about our own lived experience, sharing our personal stories, helping people by walking alongside of them, helping them navigate the other services in the community, and just being an emotionally supportive person in their lives. All of the programs, all of the things that we do are designed by peers based on our lived experience with what works and what doesn't work. They're all led by peers in recovery. The last year, across our service area, which includes Page, but also Shenandoah County and Rockingham and Harrisonburg, we served almost 1,200 different individuals. Of those, 112 were Page County residents. So Page makes up about 11% of the people who we served last year. Most of our services really are recovery services where we work one-on-one with individuals and help them overcome substance use and co-occurring mental health challenges. Last year, our recovery programs had 252 different participants, of which only 19 were Page County residents. So we know that we've got some outreach and some awareness raising to do here in this county. But our services are very much available and accessible here. We don't require people to come to our facility, which is more conveniently located in Newmarket, so we're just 20 minutes away. People can come to our offices for services, but we know that not everybody has transportation. Most of our services are home-based. We go to people because that's what meeting people where they are actually means, right? And we realize that we as peers have an amazing thing to give to others, but we can't always do everything alone. Some individuals need additional support, so we have case managers that are also peers on staff, and we have partners with clinical providers that can offer additional clinical support to our participants. We partner with therapists and psychiatry providers so that our participants have access to those services as well. We've really kind of flipped the script, whereas a lot of clinics might employ one or two peers. You know, the services are still clinically focused, but they have a couple peers that can provide that lived experience support. We've really turned the model around, where it's peers driving the charge, peers who are the primary service providers, and we have partners that are clinicians who believe in the value value of peer support and what we do and want to work alongside of us to serve the most vulnerable individuals in our community. And that's who we have focused on at Strengthen Peers since we were founded. This December marks 10 years. So we have always focused on those individuals who are falling through the cracks, for whom an alternative, peer-based service might be appropriate, might be what engages them when they have felt disempowered or unengaged by other traditional service providers. So we focus on those who are experiencing homelessness, those returning from our local jails, and those living in rural poverty. Those are the 3 core populations that we focus our outreach on. Not to say that we don't serve other people, but we focus our outreach on reaching those individuals who we know fall through the cracks because we are those people. The staff at Strengthen Peers are those people. So one of our really exciting programs that Skip mentioned is a peer support program that operates at Page County Jail in partnership with the Page County Sheriff's Department. We've been partnering with them since 2021, so it's about 4 years now, and before that we were in the jail doing our own programming, but we offer peer support in groups to men and women, as well as some individual peer support services to individuals who are struggling just a little bit more. Last year, we had 77 different individuals who we provided peer support to in Page County Jail prior to release. And that program is incorporated into the JMATE program, operated also by the Sheriff's Department. They combine our peer support with their own counseling and case management services that also follow individuals post-release and are able to support them in the community, not just with their transition back to being in the community, but also with therapy services and other services that they might not otherwise have access to because of lack of insurance or lack of providers that are able to serve them. And it's not to say that that program isn't without its own barriers. You all probably know Page County Jail is tiny. It's tiny, it has a lot of individuals incarcerated in it, and there is just one room available to any kind of services. In that room, if there is, if they have to house an inmate in there for some sort of reason, a disability, a medical condition, now our services are on hold, right? And then we have the issue of individuals being transferred to other regional jails because they don't have enough space. So if you start services with one individual, you don't know when they might be transferred to another location. I couldn't tell you what challenges the Page County Sheriff's Department has of its own between the number of individuals that experience incarceration and having to properly house them. I couldn't imagine what they're up against. But from a treatment perspective and a recovery service perspective, it's hard to maintain services to those individuals, but we do our best, and I know that the JMATE program staff, who we collaborate with very well, do their best as well.
Can you just define the acronym? I know I used it too. It's Jail Medically Assisted Treatment. Is that right? JMAT?
Lou, I know you're in there. There you are.
Yeah, it's MAT is kind of an acronym, but it's Jail Medically Assisted Treatment and Recovery, Reentry and Recovery Program.
Thank you. Thanks. And I wanted to ask you, Nikki, my understanding is, and I found this really interesting, that there's this linkage between not just the individual who's suffering from the substance use problem, but the family, and that frequently that means you lose your job, and that means businesses can't get the employees they need. And then to the extent it leads to crime and overcrowding of the jail, and the county has to pay other counties to house some of those people. And so it's a huge problem with many, many different facets to it, including taxpayers in Page County. Can you talk about the extent to which there's a need for your services in this county in particular?
Yeah. In the past 10 years, we worked not just in Page County Jail, but also in Rockingham Harrisonburg Regional Jail and Middle River Regional Jail in Verona. Between our homeless services and our homeless outreach and our jail inreach, it's a revolving door. We see the same people experience incarceration, come out, fall into homelessness, fall back into addiction, return back to jail, and just keep on cycling in and out. I can't imagine. I do know some of the impacts on families. If these are your daughters or your brothers or your mothers, you can imagine what kind of impact that's going to have on you, on your family. We have way too many kids who are being raised by their grandparents because their parents are stuck in these cycles. And we don't have enough recovery support services, enough treatment services to really help individuals and help them when they're ready. And one of the things that was mentioned about, having Medicaid and the challenges with not only applying for Medicaid and having that application process, but then having to renew it over and over again. When you are struggling with substance use and you are ready today, and you need somebody to help you today. If you have to wait for your Medicaid application to be processed, and that might take a few weeks or months, that bed at that treatment facility is going to be gone by the time you're ready, and you might be waiting even longer. Or if you have to reapply every 6 months, is that insurance going to be available when you're ready to grab a hold of recovery, to embark in the services that you are looking for and that you need? And if you are the family member, just think of the sadness and frustration if your loved one is ready, but the system is broken.
When I first contacted you about possibly participating in this panel, it was maybe 6 weeks ago, and you told me over the phone something I had read about, but I want to ask you about it now. And that was the federal grants that you had recently unceremoniously lost. Can you talk about what those grants were, to what extent they're important to your organization, and the circumstances surrounding the notice that you got or didn't get?
This year has been a roller coaster. I think for all of us, all Americans, all of us, it's been a real roller coaster. And I know that my fellow healthcare providers are continuing to experience the roller coaster. There's no end in sight so far. But for the nonprofit community, it's been really tough. Earlier this year, with the president's and the new administration cuts to federal discretionary grants, we actually had four grants that were terminated. 3 of them in one day. They were all the American Rescue Plan Act grants that were issued as recovery from the COVID pandemic. And they were grants to Virginia, to the Department of Behavioral Health and Developmental Services of Virginia, that they had then sub-granted monies to us for various programs. One of the ones that we lost that was most impactful to our services in Page County and in Shenandoah County was one supporting our recovery programming here. We also, not fortunately, but the impact of those three grants being lost was significant, but not horribly terrible, because those grants were already slated to end at the end of September. So we were already winding those programs down. We knew that there was an end to those programs coming up. They ended abruptly, and that was very challenging to deal with and to handle, but it could have been a lot worse. Then in April, it was a lot worse. We had just launched a 3-year grant from the Department of Justice for a jail reentry program, supplementing our work with the Page County Sheriff's Department, and actually working again in partnership with the Page County Sheriff's Department for a reentry program. Our focus was going to be on helping those individuals who were transferred from Page County Jail to the other regional jails to make sure they had continuation of recovery supports and that really critically important transitional case management services to help them figure out what they were going to do when they returned from whatever regional jail they were at back to Page County, to be able to access recovery services, treatment, ensure that their housing was okay, help them with getting employment, figuring out transportation. So between all three grants, it was $860,000 impact on our organization. I will say at that point we were very nervous, as you can imagine. Looking ahead, we actually approached our board of directors and presented a fiscal year budget that assumed our 2 remaining federal grants would not be renewed after the current year. So that was our assumption. We expected that the cuts were going to continue, that we were going to lose our additional federal grants, and that our federal funding was going to plummet from what has traditionally been in our history about 80% of our budget. We've been really dependent on federal funding. We like grant writing. We have a hard time fundraising from community members and businesses. We're learning though. But we were expecting our federal funding budget to plummet down to about 19% if that was to happen. Thankfully, it has not happened. We have not lost those federal grants. We did receive renewals for them. We are very happy with that. But uncertainty and risk in being a federally funded and grant-funded organization persists, specifically because the president issued one of his executive orders that had to do with an area of regulatory policy concerning all discretionary grant funding for the federal government. It added to the policies around discretionary grant funding the ability to terminate any grant for basically what's considered convenience. For anything, they could cancel any grant if they decide that it no longer supports the administration's policies or direction without notice. Prior to that, the federal regulatory policy was that you would at least get 30 days notice. At least 30 days to, figure out what you're going to do. Transition participants to other services instead of dropping them like a hot potato. Figuring out how to support your staff, giving them some notice instead of a day of layoff. That language is now incorporated into all federal grant awards, that they can be terminated without notice. And now, because so much of state grant funding comes from federal dollars, guess what? All the state grants now have those clauses listed in them as well. So while we are very overjoyed that we continue to have federal grants to support our services and state grants to support our services, we do so at the great risk and the great uncertainty that they could be pulled without notice. And the last time our grant was pulled, we received notice at 5:30 in the afternoon that it was being pulled that day and did not have an opportunity to request reimbursement. We are still about $55,000 in unreimbursed expenses.
Let me ask you one last question, Nikki, before we open it up to the audience Q&A. What has been the impact of the cuts that you just described in terms of your delivery abilities, in terms of your staff, in terms of your capabilities to provide the services that you had been providing?
In the short term, the impact was pretty severe. We had 7 layoffs. Of those, 4 were new market staff that were serving Page County and Shenandoah County. So the majority of the impact was actually on our service capacity here in Page and Shenandoah. Prior to those cuts, our capacity was to serve about 50 people in our recovery program across these 2 counties. It now has dropped to about 20 people, but we have been diligently working to rebuild, to find new funding. We have a new it's not a new partnership. We received grant funding from Valley Health last year in a mini grant. This year they came through in a much larger grant supporting our organization and our ability to offer what we call our Community Resource Center. So it's not just that we do recovery services. We are really out there to reach individuals who are struggling, and our resource center offers individuals information and referrals to community services, additional help applying for public benefits. If it's a hard case, we call Dan. Help trying to put together resumes and apply for jobs or look for apartments and things like that. And again, people don't have to come to us. We go to them. Home visits, meet you at the library. Funding come through from Valley Health. We've had some additional grant funding come through from the Department of Behavioral Health to hire on another peer specialist who'll work in our New Market office serving these communities. What started off looking like some really kind of dire straits, we've been really able to turn around and have a budget even a little bit higher than last year's budget. So we're really, really blessed and really thankful.
Thank you. Hang in there. Okay, we've got, in one moment, we want to open it up for questions from the audience. There's one fellow, Bob Ritchie, who's with the Rappahannock Rural Health Network. Bob, you want to mention just, I think briefly, you had something you wanted to...
Yeah, thank you. Piece of equipment there. Yeah, I'm with the Rappahannock Rural Health Network. We have a small grant from UVA Health to help people who are tracking their health data to manage chronic disease like high blood pressure, heart disease. If you or someone you know should be tracking their blood pressure, maybe their other health data, but maybe doesn't have the financial means to buy the equipment to use at home, see me at the back of the room. I'll sign up. We have some free information and also free equipment for folks in that situation. If you don't see me today, just reach out to Sarah. She can always track me down, and I can get it to you. That's it. Thanks.
Thank you. Oh, yes, and thanks for the plays from the sideline here. There's a resource table off to my left on that wall, and after we wrap up this evening, anybody who wants information ought to head over there, and there'll be a variety of people from a number of nonprofits, including what Bob just mentioned, to provide you more information. And you can rush the stage here to our panelists and assault them with more questions if we don't answer all of them from the floor. So with all of that, anybody have a question they want to pose? Charlie?
As our economist Dan said, healthcare is a nationwide need, and it does have impacts when you cut back. I wondered if Dr. Fate, I know that Valley Health is trying everything you can to make sure that those impacts are minimized, but what are some of the real things that those of us with insurance might expect?
I think it's a little hard to predict. I mean, it's a lot of money to figure out how to catch up. And when we talk about those challenges, we talk about how to grow into them. We're really lucky to have a community where we can continue to expand the services we offer, our cardiac services, our oncology services, our other services in Winchester. We think we can grow some of that back. I think it'd be irresponsible for me to guess at what the impact could be long term. I think what you say is fair, which is that less money is less money, and it's hard to figure out how you're going to manage in that situation. I'll add one other thing which is related to this. One question is, how do you get folks to do work maybe that costs a little bit less, or where you can find some economies? Another challenge we haven't talked about is the decrease, well, not the decrease, but the surcharge on H-1B visas. The $100,000 surcharge is a big deal for rural healthcare. We bring in a lot of doctors who train in India, who are from India, train in the States, and they're on these visas to fill spaces in rural America where where citizens don't generally sign up to go practice medicine. Trying to figure out how we're going to solve that problem is another hit in the same space. We haven't done that as much here in Page, but in our West Virginia hospitals, we have frequently had folks coming through that program, and that's another hit. It's a big deal trying to find folks who want to come and serve our communities. And these scholarship programs really work. A young Dr. Jeffrey Fike came here on a scholarship program and practiced in Page County for 12 years. People do stay where they practice, and they really do work. So that's another shame.
In the short term, I can tell you that Premiums next year are going up between 10 and 20% across the board in Virginia. That deductibles are increasing significantly. Out of pocket went up about $1,200. So it's a lot of the cost is being shifted to the consumer away from the insurance companies. There's a whole lot going on there. One other thing, you mentioned the split on how we get paid for the Medicaid. That's all based upon the economy for those other programs. We have a very good economy according to the federal government in Virginia. And so we only get 50% of all the other Medicaid programs paid for. The state's paying for the rest of them. Mississippi gets 88%. So that expansion, 2% more, doesn't affect them like it affects us. So it's big, and you can see that with individuals having to go for care and pay the uninsured rates in order to get care, that what is going to be spread among the pool will be significant, and you can extrapolate all you want to, but I'm thinking 20% a year unless we get our arms wrapped around this.
20% a year for what?
Increase in premiums year over year. And who can afford that, especially if you're a business?
Bob?
Yeah, hi. I was just wondering if the panelists could speak to whether telehealth link will continue to be billable to Medicaid. It's a really important tool for rural healthcare in the states, and I was just curious. Last I heard, it just kind of keeps getting hunted every few months.
Ironically, right now it's not being paid for because the government shut down. So the broader question is what's going to be covered for telehealth, and telehealth coverage got expanded during the pandemic to where they created a lot more telehealth codes that were paid for by Medicare, Medicaid, and the other payers have come along with that. And those approvals, like you said, kept getting kicked along. Because there's no current CR, there's no kick. So right now, you can't bill telehealth. Do I think that's going to get fixed when they finally come back in? I do think that. I don't think we're going back. I think everybody sort of likes telehealth and thinks it should be part of the ecosystem.
Do you think it will be payments will be retroactive during the shutdown period, or is telehealth telehealth?
I'd be guessing. Like a lot of things we do, our current practice is we're just continuing to provide the service, and if we get paid, we get paid.
Thank you.
Jared?
This question might be for us, but maybe for any other panelists. The Republican candidate for governor recently sought to reassure Virginians that the One Big Beautiful Bill's cuts to Medicaid wouldn't have great effects here in Virginia. Maybe because Virginia would tap its rainy day fund. I wonder if you can comment on that, and if Virginians should feel reassured that the state will protect their health care now that Congress has abdicated its role in financing expanded Medicaid.
What was the question? Frederick County's own Winston Sears. I mean, clearly, we've talked about the impacts we think will happen based on the way it's currently written. I do think there's an assumption on the part of the federal government that the states will need to pick up some of those cuts and try to make the states whole. If that's her plan, I haven't heard that, but the governor would have the ability to make up some of it. I think we've stated what we believe to be the current reality, and if she's saying something different about that, it might be based on what she plans to do. But I wouldn't know that.
Anybody else?
The rainy day fund is not a bottomless pit. It will run out.
If I could just ask a follow-up, how, roughly speaking, how much could it make up for the decrease in federal funding for Virginia's expanded Medicaid?
If I were going to guess, 9 months, it'd be done.
Thank you.
Hey, Brian, do you have a question?
Yeah, hey, thank you so much. So, Dr. Fight, this will kind of be more a question for you. So you mentioned that $60, $70 million hole. I guess I'm wondering specifically how that will affect our hospital here in Luray, if you can speak to that. And then second question, sorry, you need two. So we rely a lot on Valley Health with some of the projects that we have coming up as a county and partner with them. Could you speak to how you anticipate any of those impacts could be felt as well?
You know, again, we don't have current plans for any specific reactions to what's happening. We're in planning mode, we're in growth mode, we're trying to figure out how to get back on track to this trajectory we've been on. So I don't think that answer really changes. How does that impact Page Memorial? It's probably better to talk about it this way. It's not going to be one thing, right? As we try to stay competitive with our nurses' salaries, how much we can raise a pay grade, whether we can raise it 90 cents or whether it has to be 75 cents, it ends up working like that, right? It's a general decreased ability of generosity in the different decisions we make. And that impacts all of our health system, right? So it's not that we're going to say we're not going to spend this $60 million here, because that's just not the way our business operates. It's that we have 100 decisions we make over the course of the year, each of which might be worth a few $1 million, and each of those decisions has to be made a little more carefully as we try to grow back into this grade, right? So I think that affects Page just like it affects everywhere else, except that in Page, it's a little harder to recruit nurses, and it's a little harder to recruit doctors. And so do the rural communities sort of take that on the chin a little more? I think in that way they might, because I think that it's harder sometimes to get those folks here. You guys are really lucky to have a lot of folks who grew up here and want to work here, and you know, nurses who work in this hospital who are from here. So that doesn't change. But the H-1B visa thing makes it harder to recruit doctors to rural communities, and I think those general categories of decisions where we have to weigh one thing against another just become a little bit harder as we try to grow back into this. Remind me the second half of your question.
The second half of the question was just kind of related to some of the projects that the county looks to partner with Valley Health. We rely on some grant funding from you all, and some of those, again, some of those partnerships, we really rely on funding from you all. So I'm just curious what you all are thinking or anticipating some of those effects on some of the projects coming up could be.
Yeah, again, I'm not sure that I know the answer to that. I will say, and this is just to sound like a shameless plug for Valley Health, but I had the opportunity to present to our board yesterday the Community Health Needs Assessment, which Jason Craig, who many of you know, is our Director of Community Health, does an amazing job. We're just finishing planning for our 2025 Community Health Needs Assessment. And in presenting that, one of the things is that we are in the middle of a capital campaign. Hospital systems do capital campaigns. They typically raise $30 million or $20 million to build a new cancer center, build a new wing of a hospital. We're in the middle of a $30 million capital campaign that's entirely committed to community health. It's access to our four health needs that are, well, three of the health needs that are being addressed in our last survey. Access to care for chronic diseases. So one of the things we're doing is raising money to build some new cardiology services for chronic diseases. We are going to be setting up 2 mobile units, one for mobile cancer screening and one which is a mobile health unit that can go out to folks' homes for folks who can't get in to see the doctor and do telehealth from their home to those folks. And then we're building a $10 million outpatient mental health facility on the campus of Winchester Medical Center. That's why we need to remain an independent, strong healthcare system, because there's no way HCA ever does that when they own a hospital. They don't do a $30 million community health capital campaign. It's the importance of being lucky to be who we are and get to serve these communities the way we want to. So, sorry, shameless plug for Valley Health, but will that change over time? I mean, one way we get money is we raise it. The other way is we see patients, and that's how we are able to do what we do.
Two questions. One, I have a geriatric, severely mentally ill cousin who is in a facility. How will the cuts affect her? Because she's totally supported by, I guess, Medicaid or SSI, and I'm very concerned. I mean, she can't live on her own, she can't work, and none of us can take care of her. She's got dementia on top of it. She's not in Virginia, but just generally speaking, this population, geriatric, psychiatric patients, how are they going to be affected? It's a little scary if their care, they can't advocate for themselves, and if the care is being compromised, cuts being made
people hear the question?
Yeah, I'm sorry.
People in the
I'm not very
back?
loud.
Okay. I think Dan.
Yeah, I'll take a swing. So, and this is what I tell all the groups that are being laid off, and I address a lot of companies that are closing in Virginia. They are going down, and there's a federal program for us to come in and talk to them. Every situation, every household situation is different, so I can't really specifically address that. What I would imagine is that the threat to the facility closing is as great as a threat to her losing some kind of funding for care. She will probably be able to still receive some form of medical access, but where becomes the real problem. And that something else that I just heard too, talking about these H1 immigrants. So I meet a number of nurses that work at Western State that came here from Nigeria. When they came from Nigeria, they signed on for 2 years. They're stuck, or they go back to Nigeria. They didn't know they were coming here to get beaten up every day. And that's what's happening. That's a heck of a place to work. So there are myriad issues involved in that situation. But some of these individuals aren't going to be able to get services because of things like no possible being able to pay $100,000 to get a nurse. So I'd be more afraid of facilities closing.
Well, and that's a big problem. I don't know about here in Virginia, and I'm sure it's probably like this here, but in upstate New York, my cousin, because she's mentally ill, cannot go to a dementia unit. They won't take her, and the psychiatric hospitals won't take her because she has dementia. So she's in a nursing home, and if that place closes, she has no place to go. So it is a little scary, just the way all of this is working. And my other question was, there are lots of rumors as to why Dr. Oz was here last week. Can anyone address that issue?
What are the rumors?
Why don't you?
The question is,
One is to say he's going around to close down all the rural hospitals.
No.
That was one.
no, I thought I was more optimistic. The question was, why was Dr. Oz here last week? My understanding is that he was at an event. And so we've been very involved with the Virginia Health and Hospital Association and with Dr. Oz's department to work on some issues related to the Rural Health Transformation Grants. Oh, sorry, he's the Secretary of Health and Human Services. Yeah, Health and Human Services. So he happened to be at an event down near Charlottesville and wanted to tour a rural hospital. And Mark Nance is currently the chairman of the board of the Virginia Health and Hospital Association. So we're very plugged in with him and his administration. And so he knew of Valley Health, he knew of Page Memorial. And man, if you want to get a tour of a rural hospital, you can't do better than Travis Clark. He is of this community. He's been here forever. He knows this place like he was born there. So awesome choice by Dr. Oz.
Thank you.
Yeah, thank you.
Taylor?
So I also have a two-pronged question. They're both for Vicki. So I've been hearing that, I know in strength of care there's a lot with harm reduction, and especially with Narcan, and I've been hearing that the cuts will include no longer having access to free Narcan. So can you speak to that a little bit, kind of the impact that that would have, especially in the recovery world? And then the second part of the question is, do you foresee those cuts impacting Medicaid-assisted treatment? And if that's going to be the case, what would that even look like and the impact that would have on people that are trying to recover with support?
Thanks, Taylor. So for those who aren't familiar, harm reduction really refers to public health strategies around reducing harms and risks associated with behaviors that may not be the safest. The best example I can give you that kind of might hit home or be cross-cutting is we all drive cars. There is inherent risk in driving a car. To protect ourselves, to reduce our risk, we put on seat belts, we have airbags, we have all these safety features, but there is inherent risk in that. When we're talking about somebody who is struggling with substance use disorder, and they are not able, ready, or willing to stop, there are ways in which they can reduce their risk of overdose and dying, of contracting diseases, of just protecting themselves, such as by having Narcan on hand, having test strips so they can test their substances to see what's in it. Nowadays, we have a huge amount of fentanyl and other synthetic opioids that are being mixed in with all sorts of other substances. So somebody who is really wanting to only do one drug now is taking an opioid along with it that they had no idea they were doing. So having test strips to be able to test your substances and know what's actually in them. We also do syringe services, which I know is really controversial, and other ways in which we encourage people to use in less risky ways. If you can get somebody who is using IV drugs to stop using IV drugs and instead maybe inhale or snort those substances, the risk of overdose decreases. So we really work and do outreach to people who are still using, because even though they're struggling, they are still a human being with value, and we wish to help them in any way that we can, because if you reach somebody with non-judgment and love, the ability, the likelihood that they will get to a place where they are ready to recover increases significantly. And in our harm reduction program, I'm just going to say this, our harm reduction program has the highest rate of engaging individuals in recovery services across all of our other outreach programs. 21% of our harm reduction participants go on to engage in recovery services. We can't say that about our jail outreach services. We can't say that about our homeless outreach services, but that is the truth of our harm reduction services. The federal government has come down really hard with another executive order to eliminate any federal funding for harm reduction services, specifically for syringe services and other supplies that can help somebody go from using drugs in a more harmful, more risky way to a less harmful, less risky way. That has impacted state funding for its various harm reduction programs and sites. Virginia actually has a whole program around harm reduction. To be a syringe service provider, you actually have to undergo a rigorous process that includes a final authorization by the Virginia Commissioner of Health, which puts us under legal protection so that our employees and our participants cannot be prosecuted for paraphernalia, for having syringes and whatnot. So there's that protection. So it's a very well overseen program in Virginia. They no longer have federal funding for those supplies. They've had to pull together state funding from these opioid abatement court cases, the money's coming in from the lawsuits against the pharmaceutical companies and the pharmacies that were dispensing opioids. So that the state has been actively working to pull money from other places to support their harm reduction sites. And one of the most exciting new programs that Strengthen Peers is launching in the next couple months is actually tied to our harm reduction program and our Department of Health partners, where they're supporting us to help women who are still using and who are pregnant and who are having babies, to provide them an incredibly intense level of support. We are going to be serving about 15 women a year is our goal, with 3 full-time staff. I mean, can you imagine the level of case management, resource connection, and peer support that we're going to be able to offer this small cohort of women, and the impact we're going to be able to have on their next generation, their babies. So kudos to the Department of Health for everything it does to support individuals who are still struggling, because they have shown through their programs that there can be real success by engaging those who are still using.
Thank we started about 5 minutes late, so we've got about 5 minutes left, at which point it'll be 8:05. Let's shoot for 2 more questions. Luray?
For those in East County who don't have any kind of health insurance,
Here, you want to speak up so people can hear you.
For those in Page County who don't have any kind of health insurance, I know we have the Page Free Clinic and also the RAM Clinic. So what kind of services are available, and does anyone have any more information on that?
the website, I would go to Free Clinic has a website. So I would look at their website as well, so their eligibility requirements. If that's, free clinics open every Tuesday, 4 to 7. Okay. And it's at Page Memorial Hospital in their office complex.
Yeah, so in addition to that, the other services that are available, again, if folks qualify, is to work with Valley Health on the financial assistance program. You can go into any of our buildings and ask for that information. And folks, again, the federal poverty guideline is not a lot of money. 200% of the federal poverty guideline is also not a lot of money, but if you do qualify, you can get services at Valley Health free of charge. And if you're between 200 and 300, there's a sliding scale.
Okay, thank you.
Yeah, you bet.
Does anyone know if this also includes dental health? No.
So the best access for low cost dental health is through federally qualified health clinics.
Free clinic.
Oh, do you guys? Oh, I'm sorry, I didn't know you guys had that.
Yes, thank you.
So, and the other place is federally qualified health clinics. There's not a federally qualified health clinic satellite in Page County, but it's worth mentioning. Federally qualified health clinics. There's one in Harrisonburg. There's one in Martinsburg that has an office in Winchester, and Elton. The federally qualified health clinic system is another federally subsidized system like rural health clinics that provides a block grant for the uninsured, and so and dental care is part of their mandate. So they all have dental care.
One last question.
If you have anybody who's struggling to figure out how to access services and resources in the community, our Valley Health funded Community Resource Center program that has mobile and home-based options is something you can refer them to, and they would get one-on-one help navigating whatever service that they need. There's flyers on the table.
One last, yes.
The question is for Dan. I want to clarify to see if I understood you correctly. You alluded to the fact that the insurance companies now get a relief, whereas the people are actually having the hardship of paying more. Is that what I understood?
Say that again, please.
Okay, when you mentioned where the insurance companies were getting kind of a relief, or that's how I interpret it, whereas now the people have to pay more, pay extra.
So they're not really getting relief, except that they get to charge more. And one of the aspects of the Affordable Care Act is that there's a limitation on how much profit, how much they have to spend on what they call medical care loss. So it's a medical loss if they're helping you, right? They get to keep 20% of the premiums without any problem at all. And in general, they're pretty well sticking to that. But in order to grow that 20% in dollars to pay to their shareholders, it's to their benefit if the costs of care go up. So they're not going to do much to fight that. They do what they can to do the negotiated rates with the different facilities, but it's no harm, no foul to them if those prices go up, and they are. That's being passed directly to the consumer. That's correct.
Thank you. Okay, I want to just to wrap this up, plenty of thank yous to go around. Thanks to Living Legacy and the REC for allowing us to use this facility. I want to shout out Abby Leffler, who prepared our beautiful flyer, and many Community Works volunteers who helped put this together. Sarah Finn, our local coordinator, always instrumental. Thank you to the panelists and all of you.